hate these housekeeping. There's just too much housekeeping to go through. Like, I want to get to your speech before having to do all of this. And I'm going to move off my cards because I'm always nervous. So it's okay.
It's a good thing your IT guys are so calm, because I was about to totally freak.
Yeah, well, I would totally freak too. Good morning, everyone. I think we're going to try and get started now. Thank you so much for being here, and I want to also thank our simulcast sites in Bend, Roseburg, and Medford. My name is Jennifer Steen-Revis, and I'm one of the Komen Issues Committee members. I work at Compass Oncology as the breast cancer nurse navigator, and I'm a 9-year survivor. The housekeeping items, I know we've been talking about that a lot, but really important items. Obviously, the restrooms out the doors all the way down to the right. The men's has been converted to a women's, so I'm not quite sure where the men's is, maybe on the other side, but there's got to be somewhere around there, I guess all the way around the side. The exhibitors in the ballroom, save time to meet with them if you haven't already been in there. Lots of great information, people really dedicated in the community to taking care of patients and families. The merchandise and the photos, those are down, I think, to the left of the registration tables, down around the side, and I think that those will be opening, actually, I think they opened after keynote, so make sure you check in with them too. The CEUs, really important, nurses, social workers, counselors, psychologists, imaging technologists, physical and occupational therapists. Make sure you've signed in at the continuing education table in the lobby to pick up your specific evaluation forms. You'll receive your certificate when the evaluations are completed and handed in at the CEU table at the end of the day. And then specifically for imaging technologists, please be sure to sign in or out at the designated ASRT sign-in sheets. Those, if you've signed in already in the front, there's in the back of each one of your sessions, there's a sign out. So make sure that you sign out, especially for the keynote and each session you attend. You'll have your certificates emailed to you in about a week after the conference. Presentations for the questions, there, you'll notice on your round tables there's a lot of question cards and some pencils. Please fill out those questions about 20 minutes before the end of the session. A session attendant, Vicki, will actually be around to pick those up. I know that we've got simulcast questions coming in as well, so we'll be able to get those questions hopefully answered for you at the end of the 15 minutes. The evaluations, the general and session evaluations, you have to fill both of those out and turn those in at the end of the day. We would greatly appreciate it. And last but not least, parking. If you parked in the garage, there's parking vouchers out at the registration table. And at this time, I'd like to introduce Dr. Angela Kalishak. Dr. Kalishak is a medical oncologist and the medical director of Compass Cares, which provides resources for cancer patients and their families and end-of-life care. Specializing in palliative care enables her to focus on what matters most to her patients, whether it's relief of physical symptoms, emotional support, or helping families understand more about their loved one's care. She helps patients prioritize things that improves quality of life with a supportive, holistic treatment plan. Dr. Kalishak has been the medical director of the Providence Cancer Center Oncology Palliative Care Program since 2010, the Outpatient. Within that program, there's 2 nurse practitioners and licensed clinical social work teams that serve cancer patients in clinics at Providence Portland Medical Center, St. Vincent's, and starting March 30th in Providence Newburgh. It's my great honor to introduce you now to Dr. Angela Kalishak, who will be presenting on a new view of palliative care in breast cancer, any age, any stage.
Thank you. Thank you very much, Jen, for that kind introduction. Can everyone hear me okay? Thank you. And welcome to our distant listeners in Roseburg, Medford, and Bend. I've been asked today to speak about palliative care, which is a subject dear to me and dear to our staff at both Providence and at Compass Oncology, where I've been lucky to work for the last more than 20 years. Our goals for today are to understand the modern 2015 view of palliative care's role in the treatment of serious illnesses like breast cancer, to explore the evidence for the benefit of early palliative care in cancer treatment, evidence that's been growing by leaps and bounds over the last 5 years, and then to highlight some of the palliative care resources that are right here in our Portland, Vancouver community, and also in some of the communities where the distant listeners are currently with us. I always relate everything I do to patients, and part of understanding palliative care, I think, happens most easily when we think about the patients we serve. So I'm going to present 3 short cases to you, all women with breast cancer, all of whom have availed themselves of palliative care. I've changed the details about the stories just enough that these are not recognizable people, but they are, in fact, pictures of women we see every day and every week. The first case is M.A. She's an independent 87-year-old woman with heart disease and diabetes. 12 years after her treatment for stage 2 breast cancer, she learns that the cancer has come back in her bones and liver. A widow who lives alone, she has excellent support from her daughters and grandchildren. She has hip pain and has become more frail in the last several months. She would like to find a way to stay in her small home where she's been for more than 40 years, with the garden that she loves so much, but she has become much more withdrawn lately, and she tells her family she's worried that she's become a burden. Case 2 is C.Y. She's a 52-year-old woman, recently diagnosed with metastatic breast cancer, a cancer that has spread, and she's had radiation to a spine metastasis. She's now taking a daily anti-estrogen pill and a monthly IV treatment to strengthen her bones. Her cancer's been stable for months, and her pain is under really good control, but she has really struggled with depression, insomnia, and menopausal symptoms. She's divorced and previously really enjoyed her job, but has become more and more worried about what her future holds. Her 19-year-old daughter attends college in Virginia, and CY told her nurse in the oncology clinic that she had not yet told her daughter about her change in status. And the last case is case 3. LT is a 38-year-old woman diagnosed with stage 2 breast cancer 5 months ago. She's now receiving chemotherapy after her surgery. She and her husband both work, and they have 3 children ages 4, 8, and 11. Life is busy and was busy long before breast cancer. She reports, "I'm one of those people who, if it can go wrong, it happens to me." She's very fatigued and has had poorly controlled pain after the surgery, and now she's starting to experience some chemotherapy side effects, most prominently neuropathy. The first 2 pain medicines she tried caused significant nausea and constipation, and she's really discouraged. LT lost her own mother to breast cancer, and her entire, very loving, large extended family is in severe distress. So let's think for a minute about these 3 patients. Our first patient, in her late 80s, might be someone whom a decade ago we would consider the usual patient to receive palliative care. The second patient has a serious cancer, an advanced cancer, but she's doing really well, and now with cancer treatments being so much better, she likely has years of life ahead of her to enjoy and live to the fullest, but she's really struggling. And our third case, LT, is a patient maybe 10 years ago we might not have thought about palliative care for this patient. We are treating LT to cure her cancer and restore a long and healthy life. And yet she's someone who's receiving palliative care services also. So what is palliative care? Words really matter, because sometimes when people hear palliative care, they think scary thought. The definition from the Center to Advance Palliative Care is that palliative care, also known as palliative medicine, focuses on people living with serious illness. Important key first thought. Our focus is entirely on people living with their illness. It provides relief from the symptoms and stress of a serious illness, whatever the diagnosis, and the goal is to improve quality of life both for the patient and for the family or whatever loving, supportive circle is around that person. And I'm a person who likes the fewer words, the better. Palliative care is an extra layer of support for you and your family. I say that 25 times a week. This first video is a really short video that's a little bit of a cartoon that explains in, I think, a very understandable and easily thought about way what we try to do.
You are a bridge. It's true, or at least it's a good analogy. When you're healthy, when the bridge is sound, you can handle anything. Cars, trucks, trains, all the bumps of life, no problem. You are set. But if you're facing a serious health issue, something like kidney disease, lung disease, or cancer, the bridge starts to falter, cracks appear, and pretty soon it's hard to withstand all that traffic. Traffic that includes your own medical treatment. And that's where palliative care comes in. Palliative care is a specialized form of medical care, specifically designed for people with serious illnesses. Its main goal is to improve your quality of life by providing relief from the symptoms, pain, and stress that are an inevitable byproduct of both the disease and the medical intervention. In short, palliative care provides support for your bridge. And when a bridge is in trouble, there is nothing better. Now, palliative care, just like construction, is a team effort. It takes doctors, nurses, social workers, and other specialists, all working together with your physician to realize that extra layer, the layer that can make all the difference. It's a treatment method that makes sense at any stage of life and at any stage of an illness, because it's never too late to lessen the burden. So, next time someone you care about is facing a serious illness, remember this bridge analogy, and be sure to consider the enormous potential of palliative care.
So I want you all to know I spent hours looking for a video with a woman doctor in it and a woman patient for a Komen presentation. And I was very frustrated. I think that's a lovely video, but I had to give a little equal time, so I have one more short video also. And this next video is Dr. Diane Meyer, who's one of the world-renowned palliative care experts who practices in New York at Mount Sinai. And I was thrilled to find Dr. Meyer. Just for a few seconds, let's listen to her.
The three things that palliative care teams do very well and that really don't belong to anyone else in the healthcare system is first managing symptoms, pain, shortness of breath, insomnia, loss of appetite. Fatigue is the most prominent complaint we deal with. The second area in which we excel is in communication between the doctor and the family and the patient, and not just the doctor, there are often multiple doctors involved. And we take the time and have the skills to make sure that everyone involved in this patient's care, the patient, the family, and everyone else, is on the same page about what's going on and what this patient and family really want. It does sound like a no-brainer, right?
Thank you for playing those. We're going to go back to my slides. And it is a no-brainer. It is a no-brainer. And here's why. Everyone in this room, patient, family member, healthcare providers, and I've seen many close friends already this morning, we all know that the impact of living with a cancer illness is huge. Stress arises from simple disruption to our daily lives, which in our American culture are already packed to the gills. We might be unable to work the same schedule or for a time at all. Financial challenges from cancer treatment are an ever increasingly recognized stress and burden. We know the toll that medical care can take on families. We also know about the practical challenges, change in routine, managing appointments, sometimes just taking care of our health care becomes a huge part of life, especially during a cancer illness. Bills, childcare, transportation, caregiving needs. And the emotional challenges, which we'll talk a little bit more about, are of course something that we can never separate from the physical challenges of the illness. And those physical challenges are substantial for a cancer illness. For patients, fatigue, sometimes pain from the illness, but sometimes pain from our treatments, surgical treatments, chemotherapy treatments, radiation, nausea, neuropathy, other side effects. And then for the caregivers, for the circle of support around the women with breast cancer, there's of course the challenge, physical, mental, emotional, sometimes financial, of providing care and providing support. Some of the emotional challenges wax and wane through the course of an illness, through the course of years, months, and sometimes within a day. And sadness, anger, and worry are frequently things that patients bring to us that they wish to talk about more. The meaning of the diagnosis, what the future holds, of course. Sometimes a real temporary change of identity or a feeling of loss of identity. Treatment side effects. Lily mentioned change in sexual function, change in intimacy, sometimes change in intimacy just brought on from fatigue, never mind all the physical stuff happening. And then the change in physical appearance, the outward presentation of ourselves to the world. Change in physical functioning and sometimes mental functioning with chemo brain, many competing demands of our physical and emotional lives for the women who are being treated, and then just how to plan. How do we plan for the future? And I think we've grown to really acknowledge in the last 5 to 10 years, never mind the 30 years of my career, that it's not just the woman sitting in front of us with the breast cancer who's our responsibility. That woman comes with many roles in her life and many relationships, some of them absolutely key to her right this minute. Some of them an ever-increasing circle, coworkers, friends, community members, not even just the immediate family. And at times during treatment, the loss of independence can occur, especially if an illness is being experienced at an older age, when loss of independence is a fear to begin with. And then there are just the relationship shifts of what's happening when I'm too fatigued or at the moment having to focus on cancer treatment, what's happening to the normal function of my household, my daily life, my job. So it's the ripple effect of cancer, those ever-increasing circles. I shared this slide with one of my patients at the clinic, and she said, okay, the ripple effect is fine, but you really should be showing the days when there's also the storm at sea, not just the little ripples coming out in the calm lake. But the physical, emotional, social, and spiritual health and well-being of our patients are what we look to shore up and give assistance to in the palliative care team. So how does palliative care serve patients with cancer? First and foremost, we're trying to look at care for the whole person and the family or support system. And that care, first and foremost, has to prioritize any individual woman's goals. It has to be a partnership with the oncology team, and everyone's team is getting to be so big. It's rare, rare, rare that a woman with breast cancer meets one physician or one care provider along her journey of her illness. Surgeon, medical oncologist, radiation oncologist, physical therapist, many providers who all want to coordinate and be a true team, and that's hard to do sometimes, especially as the care gets complicated. Palliative care is also truly team care. Our extra layer of support usually comes because we link arms with other providers on our team. There might be physicians, physician assistants, nurse practitioners, other advanced practice providers, social workers. We often have a chaplain on the team with us, nurses, and sometimes a pharmacist to help us coordinate all those difficult medication interactions. I took this from the website of the Johns Hopkins Sidney Kimmel Cancer Center. I loved how simple, how direct, and how profound the promise was to their patients on the website. In describing their palliative care services, they said they strive to give close, clear communication, expert treatment of pain and other symptoms, help with navigating the healthcare system, guidance with difficult decisions and complex information. Our knowledge about breast cancer has absolutely exploded in the 30 years I've been in practice, and I am thrilled. But it can make it difficult to wade through all the information that any one individual woman and her family need for making good decisions. In addition to the complex medical conversations, there's also detailed practical information that we try and coordinate and provide. And then emotional and spiritual support, again, recognizing we are trying to serve whole people, living life with their illness. I'd like to explore with you just a few studies that have been published in the last 5 years, just the last 5 years, that show how palliative care is effective and how well it can work. So I start by saying I graduated from my oncology fellowship in 1989 and came out into practice. What was different then and now in 2015 with cancer treatment for a woman with breast cancer? Then, 1989, a lot of care still took place completely in the hospital. Not just surgery, but the chemotherapy. Many patients were admitted to hospital away from home and families to receive their treatments. And now the majority of our care is outside the hospital, outpatient clinics and cancer centers, and keeping people in their homes, in their jobs, in regular life, living regular life, so much more. Long-term survivors have become increasingly common. Increasingly common. Another great victory for all the scientific advances and supportive advances of the last 30 years. Back in 1989, if a cancer were advanced, we would treat and treat and treat with the best drugs that we had, but they were so many fewer than today. The best surgical options that we had. But today we have more and, in many cases, better radiation treatments. Now it's so much more common to hear about women speaking about their breast cancer experience and journey as chronic illnesses, even when the cancer is advanced. I had coffee with a young woman I treated for metastatic breast cancer 14 years ago. She continues to do well with monthly treatments at our cancer center at Compass, and she adopted a baby from Ethiopia a year and a half ago and is living a full and very happy life. And she has a chronic illness, and that is her breast cancer. In 1989, when cancer was very advanced, we may not have had many points of decision-making with our patients because our treatment options were less full and fewer than they are, thankfully, 30 years later. And now we have multiple decision points in care, with opportunities for discussion and choice with the women we serve, but also that means a lot more thinking through of options, comparing what the risk and potential benefits of treatments might be, what sacrifices might be made. And we spend a lot more time thinking about the future, which is wonderful, and we want to plan well for it as well. So that was oncology then and now for breast cancer. In 1989 was the year when Harry Met Sally came out. I was living in New York because I did my fellowship there and went to see this movie a few months before I packed up and moved out west to start my first real job as an oncologist. Who's seen When Harry Met Sally? Oh, good. Okay. I love romantic comedies, and that one's always been a favorite. So this will come up again. 5 years ago, in 2010, a very important article was published in the New England Journal of Medicine that literally sent waves of excitement through the oncology and the palliative care communities. It was published by a group at Massachusetts General, and it was not breast cancer patients, but it was patients with advanced lung cancer, metastatic non-small cell lung cancer, a very serious cancer. And this study randomized patients. Some patients with advanced lung cancer got the usual standard treatment, whatever was most appropriate for them, along with their oncologist making those decisions, radiation, chemotherapy, other things. The other half got that same good oncology care and was randomized right to the start of their treatment for their cancer to have the support of a palliative care team as well. They met the palliative care team within 3 weeks of their diagnosis, and they saw the palliative care team, physician, nurse, social worker, at least once a month. The other patients could still get palliative care, but either the patient and family or the physician had to request it, had to think to request other services of support for the patient. And what was so amazing about this study was that patients in the early palliative care group had better quality of life, less depression. Advanced lung cancer is a cancer that often ends in the death of the patient within a few years. And the big shockwave, people lived longer when they got the palliative care early. For many years in the oncology community, I think there was always a little concern about if we start talking about certain issues and choices right at the start of treatment, will palliative care make patients nervous that we don't want to give them our best because we're talking about giving good care all the way through their lives, even to the end of life? And in fact, these patients lived longer. In January 2011, our Clinical Oncology National Professional Society issued a policy statement based on that study that I just showed you and several other studies that also strongly suggested that increased support for patients with serious cancers really benefited them and did not cause them to make other less forceful choices in their health care. Our Clinical Oncology Society recommended that physicians initiate discussions about palliative care and palliative treatment options shortly after patients are diagnosed, not to wait until the patients felt worse or choices for treatment were more limited with chemotherapy or radiation. That was in 2011. In 2014, another study came out, this time from a very large group in Canada, and this time not just lung cancer patients, also breast cancer, ovarian cancer, and colon cancer. And similar sort of design, patients were randomly assigned to standard oncology care in one group, and the other group to early palliative care with their cancer care. And it wasn't a huge amount of extra treatment. An initial comprehensive assessment, and then monthly palliative care outpatient visits, and more phone support to answer questions and help troubleshoot problems. And the patients receiving palliative care had much improved quality of life at 4 months, and rated their satisfaction with their care as higher than the patients who were not in their group. And last but not least, in May of 2014, just last year, there was evidence published that early palliative care didn't just benefit the patients, didn't just benefit the women and men with the cancer. It seemed to have substantial benefits for the caregivers and family members as well. This study, done at multiple centers, showed that when patients and caregivers had immediate intervention versus 12 weeks later, the caregivers in that group rated their own quality of life as improved, and they had less depression than the caregivers in the first group. And this was really impressive to me because the amount of intervention was a single in-person visit and then monthly phone calls to support the caregiver, answer questions, and help with access to resources. Pretty impressive. From those studies and other studies, there's been a huge drive in the last 5 years to integrating more palliative principles into our cancer care for breast cancer and other cancers. First and foremost, clarification of the goals of the patient and the family as we navigate the treatment together. Of course, pain and symptom management, education about the complex treatment choices and strategies for coping with side effects. Sometimes we can't eliminate them totally, but we can often make them better. Advanced care planning, which actually should be part of all good health care, and in Oregon and the Pacific Northwest, that's really how we view it. Guidance with decision making when those complicated moments arise, and then the emotional, psychological, social, and spiritual support, which sometimes takes place in our offices in our cancer centers, but often involves linking the women we're caring for to other community-based resources. And because our patients often travel to different places for their care, it's really important that we, the team, as Dr. Diane Meyer said, that we become the super communicators, that we make sure all the doctors are on the same page, that we make sure that the woman with cancer and her family have the security of knowing we're all communicating, not just with her, but with each other as well. So knowing all that, let's revisit our 3 cases. Remember LT, she's our youngest patient. The young woman receiving treatment for stage 2 breast cancer with 3 kids and a job and a spouse and a very busy life. Partnering with her oncology team, the palliative care team met with the patient, and the palliative care physician helps design a medication plan that works for her surgical pain and the neuropathy, but doesn't give her so many side effects. Previously, she'd sort of abandoned ship on the pain meds, thinking she would only get trouble from them, and was really having difficulty managing her active life with the pain that she had. The social worker helped to provide some guidance in a really critical, important, front and center issue for LT, how to explain her illness and cancer treatment to her 3 kids, all different ages, all different developmental stages. The social worker also connected LT's family to some really helpful community resources. And at LT's request, the physician and social worker had a family meeting for some of that big, loving, very distressed extended family to help talk about the ripple effect of cancer in their lives, and helped them all strategize together on how to meet the stress of LT's illness and also move to the future more hopefully and happily. Not surprisingly, Having lost their mother, seeing their sister with the same diagnosis was a traumatic event, and the team together helped not just LT and her husband, but those sisters and brothers as well. And then as time went on during the latter parts of finishing chemotherapy and then radiation, the physician really helped LT with a fatigue management plan. Fatigue being, as Dr. Meyer said, one of the first things people come to us to talk about. And so there were referrals for an exercise program and some other things that were very helpful to her. And lastly, our nurse met with LT and her husband to discuss intimacy and sexuality concerns that they had. And then CY, our 52-year-old woman with metastatic breast cancer that we hope is truly going to be a chronic illness for years for her. Again, partnering with the oncology team in close communication, the physician and nurse practitioner in this case addressed her menopausal symptoms, the fatigue, and the insomnia, which was so debilitating for her, not being able to get a good night's rest, that it would really start to impact her mood as well. The physician and social worker connected CY to wellness resources, yoga and meditation classes, as well as an exercise program that really, really, really positively impacted her quality of life and her thoughts about the future. And the social worker assisted her in finding a support group of women with the same diagnosis to get extra support from the people who truly are the experts. CY had not been connected to a faith community in years, but really enjoyed the connection with the chaplain on the team who made supportive visits as were needed, and the social worker, the physician, and the chaplain helped CY last year when her daughter came home from spring break to sit and talk about the cancer treatment, the prognosis, and partnering together as a family, honestly, but with the tools that they needed to move significantly more hopefully into the future. It's always our parental desire to shield and protect. And sometimes we need help in navigating those conversations. In our third case, lovely MA, our 87-year-old patient. The oncology team requested the palliative care team's help, and the palliative care physician took time to speak to everyone involved in her care. The cardiologist, the endocrinologist, all the physicians who had been part of this woman's team for decades, who knew her well, and were very helpful in crafting a plan that made sense. We created a pain management plan that helped control symptoms, but that paid very close attention to increasing her risk of confusion and the chance of falls, because no one wanted to run the risk that another event would happen that could possibly make it harder for her to stay at home. And after a few months, the physician, social worker, and chaplain met with MA and her daughters, and the patient and family decided hospice care would be appropriate at this time. Hospice is palliative care, but it's palliative care at the end of one's life. With hospice support, nurse visits, eventually a personal aide to help with bathing, volunteer, chaplain, and social worker, a different team from our office-based palliative care team, the patient was able to stay in her home for the remaining 4 months of her life, enjoyed her family, her garden, and her independence while she still had it. And her family felt so good to have honored that wish. 3 very different cases, 3 very different women at different places in life who I think all utilized palliative care in a way that really improved the quality of their lives and the quality of their families' lives as well. So this little cartoon diagram is something that I love to show again and again. You'll see diagnosis on the left-hand side. The arrow starts, and at diagnosis, a patient or a woman with breast cancer might be getting mostly curative, disease-directed, control the illness, or hopefully make it go away care. But there might be some palliative things that she would need, supportive, symptom-reducing medications, psychological support. As a serious illness continues or recurs, the person with the illness over time might have fewer options to shrink the tumor or control the cancer, but the options for improving quality of life and managing symptoms well are still there and more important than ever, and the palliative care team might be more involved during that time. You'll notice that person with illness is at the bottom, but family is also there, caregivers. And I always count the rest of the medical team as part of those caregivers. We in the palliative care team want to support not just the woman with cancer and her family, but also the other physicians, nurses, staff, who will be giving their best and doing their all for her as well. It's a big group, and it's a true honor to be part of care in that kind of way. You'll also notice that if death should occur, as it will someday for all of us, but if death should occur related to the cancer, you'll notice that the line keeps going after the death of the patient. And that's because we recognize that part of our job is to help support patient families and caregivers, physician, neighbors, coworkers, friends, in the grief that they might experience if a patient does die. It's a different view of how to give medical care to not just patients with cancer illness, other significant serious illnesses as well. Palliative care is in the mix for more and more illnesses. So I'm going to pause now and shift gears and talk about palliative care in our communities in Oregon and the Pacific Northwest, because life is better here, and I think healthcare is too. Slightly biased. I'm slightly biased. Palliative care in the Pacific Northwest has a long tradition. Our healthcare community here values palliative care. There have been successful, strong inpatient hospital palliative care programs here for a couple decades. And the palliative care community in Portland and in Oregon as a whole is very collaborative. We share our education, we share our expertise, we share innovations and celebrate them. So much of the time we hear about healthcare as competitive, a competitive workplace. The palliative care community is all about collaboration and about the commitment to serving our cancer patients and their families well. But there's a new challenge, and that is that there is a growing population of people with serious illness, not just cancer, who could probably benefit from palliative care. Just as those studies have come out for cancer-related illness, there have been increasing reports of studies for patients with heart failure, patients with kidney disease, very elderly patients, because we're living longer now in the US, who might have 3 or 4 or 5 chronic illnesses. How to help quality of life for these people, for all of us. And with the baby boom generation, there are a lot of us who may need these services. And right now we have a limited workforce. So that's our challenge here in the Pacific Northwest and all over the country. Many of our established programs are in hospitals, and the outpatient clinic and home-based programs require different models, different staffing, different forms of support. The work is well underway here, far in advance of some other places in the US, but it's a challenge and we recognize it will continue to be. And the solutions will be found in what we've always done, in collaboration. We recognize that we need education to boost symptom management skills. Almost every oncologist I know is already pretty darn good at symptom management. The oncology teams, the wonderful oncology nurses, they are all good, but we can raise all our skills and help to bring more palliative care into every interaction that a woman with breast cancer might have with her healthcare team. Similarly, communication skills. We are recognizing what an art it is to take complicated medical treatment choices and help to say them in plain language, explain short-term and long-term consequences of any particular choice, and then to make sure that in a time of high stress, high fatigue, anxiety, sadness, that we revisit the choices and make sure we continue to communicate all along the way of a person's illness so that they are living their lives with their illness. And we just plain old need to increase the number of palliative care providers. And that, in fact, there are now certifications for nurse practitioners, and there's one coming for physician's assistants. And we have to figure out a way to get all these terrific services even into rural communities and places where there might not be as many physicians. So telehealth is something that's being looked at across the country as well. How am I doing on time, Jen? Okay. So let's take a look just at some of the community oncology palliative care resources. I had a lot of fun phoning a couple colleagues in different hospital systems over the last couple of weeks in preparation for this talk. Where I work, of course you always know where you work best, Compass Oncology. I'm the only physician who's doing palliative care as a specialty now, although all my colleagues are trying to add more palliative care into their practice. We have a nurse dedicated to our team, but again, I consider every oncology nurse I work with as an oncology nurse who practices palliative care. We have social workers at our Rose Quarter Cancer Center and the West offices. We actually have appointments where patients can come in specifically for palliative care. Providence Cancer Center, the other place I work, as Jen mentioned, has the 2 nurse practitioner social work teams at Prov Portland and Prov St. Vincent, and starting March 30th at Newburgh. And there's also a home health team for people who are homebound, so nurses and social workers can go out into the home. My legacy colleagues will be opening their outpatient palliative care clinic for cancer center patients within the year. And they have a partnership with the OHSU Knight Cancer Institute. And OHSU has a thriving palliative care service. Some of the workers in this very room right now. And they have an outpatient clinic at the Center for Health and Healing, and also at their community oncology clinics, 1 day a week, a palliative care team there as well. Peace Health in Vancouver, a palliative care RN doing phone support, and Community Home Health and Hospice also in Vancouver with the home-based palliative care team serving mostly the homebound Kaiser patients. The Kaiser network, terrible oversight, accidentally took the slide that didn't have the Kaiser team on here. The Kaiser team in Portland and the greater Portland area has a wonderful outpatient and inpatient palliative care service to provide support for their patients as well. And then in Bend, for our listeners who are there, the Advanced Illness Management Program at St. Charles Medical Center has wonderful outpatient and inpatient services for women diagnosed with cancer and other cancer patients in their community. So in Oregon, palliative care is definitely reaching farther and farther into our communities to serve our patients as well as we possibly can. And this is our commitment. The entire palliative care collaborative network of physicians, social workers, chaplains, nurses in Oregon and beyond. We may be experts on cancer treatment, but our patients, the women we serve with breast cancer, are the experts about what matters most to them and to their families. And as we create the best possible health care for them, we have to always focus on what matters most and know what matters most and communicate it well to each other. So I encourage all of the survivors in the room to ask those questions. Tell us your thoughts. Ask your oncology team about palliative care services and support for you or a friend or a family member. And also, really importantly, to ask it of the people who provide your health care in the insurance industry as well. More and more insurance companies in Oregon are paying for a greater number of palliative care services. Everyone recognizes how important this is and what a difference it makes to quality of life. So Harry met Sally. Okay, everybody knows this scene, right? If you have not seen the movie, I am not going to spoil it for you. It's probably on Netflix, I bet. Meg Ryan, Don't You Love the Hair, from 1989. In this scene in a diner, Harry and Sally have an important conversation, and Meg becomes rather expressive. And an elder woman sitting at a table nearby says, when the waiter comes to her table, "I'll have what she's having." I'd like everyone to consider one of the things we really want to have is palliative care, any age, any stage, for women who could benefit from it who have breast cancer. So I want to thank my teams, because as a team is how we do what we're able to do. So I have a Providence Cancer Center team and a Compass Oncology palliative care team. And I owe great debt to them for making it possible for me to have this wonderful, wonderful job of service. And then I asked Bridget, who ran the program, helped create the program committee and support for us speakers, when the first Komen Issues conference I attended to speak was. And it was in 1996. So what a great thing to pause a moment and realize that this support has been so strong and ongoing. And in fact, I was stopped in the room by a patient I treated 20 years ago who now lives in Joseph, or near Joseph, in the Wallowas. And it was such a pleasure to see her. But every time I've been honored to be a speaker at a Komen presentation, I've ended my talk with a slide of my two kids. And in 1996, it was one of those Kodachrome things, you know, the old cardboard things with the slide in the middle, of my two girls running on the beach. And this is why this matters. This is why this Komen meeting matters, why palliative care matters. I'd love to take questions. Thank you to the AV people, too, for troubleshooting my videos.
Does anybody have any questions in the audience? You do? A lot of people are writing them down on the card. I can take a verbal one if you can.
I wanted to know if Medicare or Oregon health plan covers palliative care.
Do Medicare or health care plans in Oregon Health Plan cover palliative care? Good question.
Yes. Medicare covers physician visits. Medicare does not cover some of the home-based visit programs, but it does cover, for example, physician or nurse practitioner visits in the clinic. Oregon Health Plan also will cover physician and nurse practitioner visits in the clinic. And in fact, one of the Oregon Health Plan providers, Care Oregon, also has a benefit, an insurance benefit for home-based teams, so a nurse and a social worker to visit patients and families at home. They will also pay for that. Not every Oregon Health Plan or Medicaid insurance provider pays for the home-based part of the team, but they do pay for the visits at the clinic.
Okay, we've got some other ones. How does a family therapist fit in as part of the palliative care team?
Therapists and mental health providers, psychologists, licensed clinical social workers who have counseling experience are all part of the palliative care team. I would say that I don't know currently any programs who specifically employ a family therapist only to assist in a palliative care team, but frequently we make referrals to family therapists for patients to access, to discuss, and then collaborate with us in meeting some of the supports for stress, anxiety, and conflict that can sometimes occur when different family members and patients' goals may not completely line up. So we consider all those providers a part of our extended team, sometimes not within our walls, but helping to give care in the community.
Okay, we have one here from Roseburg. What specific training do palliative care teams undergo?
That's a great question. Palliative care teams, if they consist of a physician, for example, there is a certification, just like one has to take special training to be an oncologist, for example. There is special training to acquire the skills to become a palliative care physician. Now there is a fellowship program, and up until a few years ago, doctors like me could sort of apprentice and then get the required hours of training and lecture work and then have the board certification test. But I think it's more important to say that our teams as a whole get extra training in symptom management, extra training in communication, and believe it or not, extra training in teamwork, because it's a special skill to work as a team also, to make sure that we respect and highly utilize everyone's different skills. So we get symptom training for pain and other symptoms, communication training, team training to work well with each other, and then also training on how to take good care of ourselves as well, as I believe all healthcare providers should.
Couple more here from Roseburg. What advice would you give an individual considering palliative care as their specialty?
Who are you is the first question that I have. I would say that there are multiple wonderful fellowship programs in the Northwest and the West Coast. I would say this is one of the great privileges of medicine. Palliative care is hard work and committed work, but it is work that really fuels the soul. And my advice would be think strongly about it because it is for people who enjoy working together with others, and meeting the most incredible people, navigating critical times of their lives, there is just nothing more satisfying. And we probably should say I'm a little prejudiced about this, so please email me. My email's on the last slide. Happy to talk more.
Two more. Is networking and resources the most important concern? This is from Roseburg.
Say that again, Jen?
Is networking and resources the most important concern? And I'm not sure if it's asking of palliative care.
I'm not sure the spirit of the question, but I would say that resources are always a concern because teams like this are obviously a big investment for clinics and for hospitals. And so resources are a concern in our healthcare system that has so many competing needs and everyone hoping for more budgets, more support. So I actually think that resources are a huge concern, and networking is a way to maximize use of our resources. So people in palliative care frequently are master networkers at getting our patients what they need, even if it might not exist in our very four walls. Oh, yeah. I think there's a palliative care provider in one of the remote audiences. If I didn't make it clear enough, almost all hospitals that I know of in the greater Portland area have inpatient palliative care teams that have been in existence for years and do absolutely wonderful work and collaborate well with us, their colleagues outside of the hospital. But it's really important to know because often when people are admitted to hospital for surgery or for a complication of treatment, there is a palliative care team there in the hospital at the ready to serve the patient and the physician.
Great.
Sorry if I didn't make that clear enough.
Anything else? One more. Go ahead. I have to repeat the question too for our audiences and our simulcast sites. So the question is, how do you start to implement palliative care in, it's kind of a shift that we're trying to create now with, when it's appropriate. And obviously with the presentation today, palliative care is always appropriate. So how do we as providers start to shift that and having other people, physician buy-ins and those types of things? Can you help to answer that real fast?
I can only speak from my own experience here in Portland and in practice in two different places, at Providence and at Compass Oncology. And for the remote audiences, one specific question this nurse navigator asked is, how do we get people to stop equating or thinking that hospice and palliative care are exactly the same thing? And it is actually on the ground, so to speak. My own experience has been that it's interesting a nurse asked this question because in my oncology practice, I would say that there has been a literal ground shift in the last 5 years, between when we first started doing this work 5 years ago, and some physicians say, oh, I'm a little nervous to talk about palliative care with a 28-year-old or a 30-year-old. But in speaking about what is it we want to give, better quality of life, better symptom management, almost everybody says, yeah, that sounds good to that. And my experience actually has been that it has been the nurses, chairside and bedside with the patients, who advocate to the physicians. And in my own practice, physicians who 5 years ago would say to me, oh, I'm really not sure I want you to come and see them because then they'll think I'm not really as hopeful for them. Now, allow the nurses to just recommend a patient if they think a patient could possibly benefit. I did actually have a physician 5 years ago say to me, I'm okay with you see a patient of mine as long as you never say the word death in the patient room, which there are times when, of course, it is appropriate. That physician, I'm gratified to say 5 years later, will grab my sleeve as he's coming out of a room and pull me in and say, oh, there's somebody I want you to meet. So it is slow, but growing momentum, and I think physicians are committed to their patients, and they're also scientists. And the data that's evolving is very compelling. And whenever I see a patient, I always ask, so what did Dr. So-and-so tell you I do? And then the patient will either get a sly smile or kind of go, well, you know, he was all over the board. I wasn't really sure why he told me to, and then it gives me the opportunity to talk about our quality of life plans and our desire to really support the family, their family. And it is an evolving momentum, but I need to also say, we all need to practice palliative care every day, every patient, but the number of people who will need us in 10 years, not just in cancer, will be enormous. So the other obligation of palliative care teams, as I mentioned, is to help to educate and support all of our colleagues in getting those extra skills as much as humanly possible.
I know we need to get the room converted over for lunch, but I think Lily has one more question for us.
Hi, Lily.
I just wanted to comment that when we brought forward Tom Smith at Johns Hopkins, who I'm sure you know,
Yes.
fabulous, our director of palliative care, and I saw some resistance of inviting him in. So I've asked everyone to refer to him as our quality of life coach, and that he gets so many referrals. We've had to hire more palliative care providers. So that has worked. It takes that, it removes that palliative care term, but we want people to embrace it until they are able to mentally, quality of life they get.
Yeah, and they also get what matters to you. I'm here to focus on what matters to you right now, not on the chemotherapy necessarily or the radiation, but what matters to you now, and how can we make your quality of life better.
Okay.
Thank you so much.
Thank you so much. Thanks so much, Dr. Kalishak. Wonderful, wonderful. My favorite. I can take that down to them if you'd like. Did you already get your plug-in?
I've got that, and I need to.
Is it stuck?
This is when the bifocals are a problem.
So cold in here. Thank you.